Good afternoon and happy Easter to everyone. Thank you for joining us. We're so happy to have you with us. And we are going to talk about, from a kind of common sense perspective, what to worry about with blood diseases. So, without further ado, I will turn it over to our founder, Dr. Randall Maxey.
Thank you very much, Dr. Barbara David Stevens, Dr. Ivan Walks, and Dr. Hines, and Dr. Lawson, and Simon. So I went to church today, and they had a drama where they talked about the crucifixion, and the devil was portrayed by an ICE agent. I thought it was very entertaining. But happy Easter, happy Resurrection Day. Let's put up the slides, Simon, if you would. We want to talk about a disease that affects the blood of people, and especially African Americans. And I'm presenting this in honor of a cousin of mine whose name is George. And George hopefully may be able to join us today. But George was one of the first Green Berets in Vietnam. And he jumped behind enemy lines more than 380 times. And in the process of being in Vietnam, he was exposed to Agent Orange and burn pits. And subsequently, he developed a disease called multiple myeloma, which is a life-threatening plasma cell cancer. It's often diagnosed late due to very subtle early symptoms. We know that African Americans have 2 to 3 times higher incidence of this disease. And we also know that early detection significantly improves survival. Next slide. So there are symptoms you should not ignore. Barbara, we can take this slide?
Sure. What we should not ignore: persistent fatigue due to anemia, bone pain, especially in the spine or in the ribs, recurrent infections that are due to immune suppression, and kidney dysfunction, often silent initially.
Next slide.
Who's at risk? Well, if you're over 50, you're at an increased risk. If you are of African American ethnicity, you are at risk. If you have a family history of hematologic malignancies, not necessarily multiple myeloma, you are at an increased risk. And exposures to toxins, benzene, such as benzene, pesticides, and radiation. I notice you don't have Agent Orange on here. Were you saying that Agent Orange was a contributory factor or the
Oh,
causative
yes,
agent?
yes, it is. Definitely. Definitely it is. Next slide. So, what do you should expect if you go to a doctor and they suspect this disease? Is they'll do a blood count, CBC, to see if you have anemia. They'll do something called a serum protein electrophoresis, which is a blood test to look at how the proteins go on a graph. They do something called a free light chain assay. Light chains are molecules versus heavy chains, and they clog up the kidneys, and we'll talk about that later. And you're going to probably have a bone marrow biopsy. That's what the definitive diagnosis is made when they actually go into your iliac crest, which is one of your hip bones, and look at the bone marrow because this is the disease of the bone marrow plasma cells. Next slide. Dr. Neighbor Stevens.
Okay, so the incidence of the disease versus age. You should not be surprised to see the dramatic increase in the height of this line at the age of 50 to 55. And it tops out at age 80. The graph does. Does it Is it frequent in people post 80?
Not many people get there, but yes. Yes, indeed. I think the graph just ran out of paper. Uh,
Okay.
Next slide. Dr. Walks, is
You're on
Dr.
mute.
unmuted? And take this, Barbara.
Okay. Ethnic risk comparison. Comparing whites, African Americans, and Hispanics. The middle bar, which represents African American, as you can see, is quite tall and much taller than the other two at about three 3%. No, that can't be 3%. I'm not sure what that three represents. But needless to say, the bar graph tells the story, with African Americans having twice as much and a little more than twice as much of the other ethnic distributions.
Next slide. Let me know when Dr. Walks is unmuted.
I'm unmuted now.
How you doing, sir? You want to read
Good
this one?
afternoon. Absolutely. What is multiple myeloma? It is a malignant proliferation of plasma cells, production of monoclonal immunoglobulin, infiltration of bone marrow, systemic organ damage, CRAB features.
Take the next slide too. I think we explained it in the next slide.
What is CRAB in multiple myeloma? CRAB helps doctors understand how multiple myeloma affects the body. Each letter represents a key problem that may require treatment.
Take the next one too.
Okay. CRAB criteria: hypercalcemia, bone breakdown releases calcium. That's the C. Renal failure, you have light chain toxicity. A, anemia, marrow replacement. And then B is bone lesions, osteolytic destruction.
Next slide. Finish this one, Dr. Walks. Finish this series.
Okay. So breaking them all down, the C for high calcium or hypercalcemia, meaning high calcium in the blood, too much calcium in the blood from bone breakdown. Symptoms of hypercalcemia: fatigue, confusion, constipation, and increased thirst.
Next slide.
We went past the R, I think. There we go. R, kidney problems or renal failure. Myeloma proteins can damage the kidneys. Symptoms: swelling, fatigue, changes in urination, and abnormal labs. A, anemia, low blood count. The cancer cells crowd out normal blood cells. Symptoms: tiredness, weakness, shortness of breath, and pale skin. And then the last one, B, is bone damage. Myeloma weakens bones and causes holes or lesions in the bones. Symptoms: bone pain, fractures, back pain, and loss of height. CRAB.
This is the last one for you, Doctor. Go ahead.
Okay. Why CRAB matters. If one or more CRAB feature is present, then treatment is usually needed. Early detection helps prevent serious complications.
Next slide. So bone disease mechanism. Increased osteoclast. These are things that break down bone, osteoclast activity. And we know that there's a certain type of signaling that is overactive that breaks down bone. It suppresses the building of bone or osteoblasts. Osteoclast breaks down bone. Osteoblast creates bone. And there should be a happy medium between the two. But in this disease, you have more activity of the things that break down the bone. it suppresses that part. So this gives you more bone lesions in your bone, increased fracture risk and pain, and also pathologic in rheumatoid arthritis and postmenopausal states as well. Next slide. Dr. Neighbor-Stevens?
Renal injury pathway. Free light chains are filtered by the kidney. The tubular toxicity and the cast formation act like plugs. This leads to what's called cast nephropathy, which is a, a, a something that is formed that mimics the nephron where it was created, or the tubule where it was created, or so that's why it's called a cast, and progression to chronic kidney disease.
Next slide. Dr. Lawson? Is Dr. Lawson unmuted?
Not
Not yet.
yet. Looks like he is. There we
Yeah, I'm
go.
out here. Immune dysfunction, suppression of normal immunoglobulin production, increased susceptibility to infections, reduced vaccine response, and frequent bacterial infections.
Next slide. I'm going to take this with Dr.
Epidemiology, oh, I'm good. Epidemiology, incidence increases with age. Median age of diagnosis is 65 to 70. African Americans have early onset, and MGUS progresses at about 1% per year.
Next slide. So,
Comorbidity, CKD. Common complications of myeloma reduces drug clearance, increases treatment toxicity, and worsens overall survival.
next slide. Dr. Barbara Neighbor-Stevens?
Comorbidities that are seen along with multiple myeloma include problems with hyperglycemia because of the steroid treatment of multiple myeloma. There's an increased infection risk. A lot of that also can be linked to the steroid use, steroid treatment. It accelerates kidney damage, that is diabetes, and we know about that, and it requires very tight metabolic control. When we say tight metabolic control, we mean you got to get your sugar down, keep it down.
Next slide. Go ahead, Dr. Neighbor-Stevens?
Another comorbidity that is associated with multiple myeloma would be various forms of cardiovascular disease or heart and vessel disease. There's increased inflammation. There can be treatment-related cardiotoxicity. That means that the treatment might damage the heart or interfere with heart function. There's a higher mortality risk if cardiovascular disease is present, and it requires cardiology co-management along with the hematologist oncologist of the multiple myeloma.
Next slide. So there's also a comorbidity with thyroid disease. The people may have fatigue, overlaps with myeloma, metabolic dysregulation, can also mask early symptoms, and requires endocrine evaluation. So we talk about need to bring in the cardiologist, the immunologist, the endocrinologist, as well as the nephrologist. It needs to be co-managed. Next slide. Dr. Wilkes?
Comorbidity. Sickle cell disease. Overlapping bone pain symptoms. Chronic anemia complicates the diagnosis. Increased renal vulnerability and high-risk population.
Next slide. So
Environmental risk factors. Agent Orange exposure linked to plasma disorders, benzene exposure in industrial settings, pesticides in agriculture, and radiation exposure.
Dr. Lawson,
Diagnostic workup, serum and urine electrophoresis, bone marrow biopsy, imaging, MRI, PET, CT, and light chain quantification.
next slide, Sam. So
Bone marrow, oops, bone
in
marrow biopsy performed under local anesthesia, typically from posterior iliac crest, evaluates plasma cell percentage and is essential for diagnosis and staging.
imaging in myeloma, X-rays detect bone lesions, MRI identifies marrow involvement, and PET and CT scan shows whether how active the disease is, and CT evaluates the structural integrity of the bones. Next slide. So the treatment overview. One, proteasome inhibitors, and we don't need to know all these medications, but that your person who's a cancer specialist will deal with these. Immune modulators are important. Corticosteroids, such as dexamethasone, and combination therapy does improve outcomes. Next slide. Dr. Barbara Neighbor-Stevens.
Advanced therapies include CAR T therapy targeting, I don't know what BCMA is, but it's some component of multiple myeloma. CAR T therapy is an immunologic therapy. Bispecific antibodies, stem cell transplantation, and improved survival in refractory disease to the more standard therapeutics.
Take the next slide too, if you would.
Treatment toxicities that may be encountered: peripheral neuropathy, myelosuppression, that means suppression of the other bone red cell types, infection risk, and cardiotoxicity.
Next slide. So one of the main reasons I wanted to talk about this is a lot of people want to do everything holistic, but there's risk in doing that. It delays evidence-based treatment. It's unregulated supplements and potential kidney toxicity and drug interactions with chemotherapy. So holistic may be good, but it's something with multiple myeloma you have to be very careful with. Next slide. Dr. Neighbor-Stevens, take this one if you would.
Survival, treatment versus no treatment. It doesn't say so, but I'm highly suspicious that that orange line is the non-treatment line because
Mm,
practically don't survive.
yeah.
And the treatment line, the blue line, shows a marked improvement in your survival percentage.
That's why you get all the graphs. You're so smart. Next slide.
I was wondering why you do that. I was going to ask you.
Take this one.
Key point to remember: medical treatment improves survival significantly.
Next slide.
Disease progression without treatment again shows almost straight line up if you don't get treated, and your chance of the disease continuing.
So usually 8 to 10 years after diagnosis, you die if you don't get
But
treated.
generally, is it usually diagnosed that soon? Because all of the people that I have observed with the disease died much sooner than 10 years.
Well, the 10 years is with the treatment.
These were on treatment,
Mm.
which
So,
goes, I guess, to underline the
yeah,
difficulty of treating this disease.
and what goes with it. Next slide. Talk about this, Barbara.
Key point, cancer can worsen silently without proper therapy. And
Next,
if I may, I'd like to add, I even know or knew a hematologist oncologist that multiple myeloma caught. And
next,
I'm sure he was quite aware of the signs and symptoms. That was his business. But it can be very sneaky.
oh yeah. Next slide. Dr. Walks, next two slides.
Key point, myeloma can damage kidneys over time. Next slide, please. And this is a graph that shows that decline in kidney function over time. From great kidneys functioning at 90% or more, over the course of 5 years, it looks like that kidney function can decline. And I'm assuming, Dr. Maxey, this is without the treatment, just letting the disease ravage your kidneys.
Yes, sir. Next slide. Dr. Lawson, take the next two slides.
Holistic care role, helpful for support, but and I think this not just for multiple myeloma, but for a whole bunch of things,
Hmm.
often does not treat the cancer itself. I think it's a key point.
Next slide, take that, Dr. Lawson.
Vitamin therapy risk in multiple myeloma.
Take
Fat
this.
soluble vitamins, why they matter. Vitamins A, D, E, K accumulate in the body, not easily excreted, and higher toxicity risks in chronic disease.
Next slide. So these fat soluble vitamins versus water soluble vitamins. You want to take this, Dr. Neighbor Stevens?
Sure. So vitamin A has the highest solubility risk fat versus water soluble. So it's at 90%. Vitamin D is just a hair below it. Vitamin E is at 80%. Vitamin K is a little bit less than that, it's 75. And vitamin C is all the way down at the bottom, which I take it to mean that the accumulation risk is the least.
And all the things that these vitamins can do bad get increased in the presence of multiple myeloma, especially if it gets absorbed by the fat. Next slide. Go ahead, Dr. Neighbor Stevens, take this one and then we'll go to Dr. Walsh.
Vitamin A toxicity, liver damage, bone pain, which confuses the picture of the myeloma symptoms, and increased fracture risk.
Dr. Walsh?
Vitamin D excess, hypercalcemia, kidney stones, and vitamin D excess can actually worsen the myeloma bone disease.
Dr. Lawson?
Calcium levels versus vitamin D dose is normal, moderate access, and high dose use high calcium levels.
So these are supposed to be life-sustaining vitamins, but they can be very toxic in this disease. Next slide. Dr. Neighbor Stevens?
Vitamin E risk, increased bleeding. It interferes with any chemotherapy that you might be taking, and it may worsen the outcomes in multiple myeloma.
Next slide.
Vitamin
Vitamin
K
K.
concerns, alters clotting pathways, interacts with medications, and risk in complex patients.
Dr. Walks?
Clinical takeaway. Fat soluble vitamins can accumulate and harm patients. They're particularly dangerous in multiple myeloma.
Next slide.
Best approach, combine medical therapy with supportive holistic care. I
Next
think
slide.
this is the best approach for almost everything, isn't it, Dr.
That's
Maxey?
right.
Oh, yeah. Yes, indeed. Next slide. Dr. Lawson?
Integrated care model. Hematology plus nephrology collaboration, endocrinology for metabolic issues, cardiology for treatment effects, and multidisciplinary improves survival.
We even need psychiatrists, right?
That's right.
Next slide.
Always need psychiatrists.
Okay. Dr. Neighbor Stevens?
Public health impact, high healthcare cost burden, disparities in access to care, surprise, surprise, delayed diagnosis, common, and opportunity for targeted screening. I've never seen a screening for multiple myeloma. Have any of you? I mean, like a health fair or someplace like that that's going to be held in the African American community. I've never seen that.
I haven't either. We need to think about it. Next slide.
Me?
Yes.
Health disparities, underrepresentation in clinical trials, and ongoing struggle, reduced
Mm.
access to transplants, socioeconomic barriers, and need for equity-focused interventions.
Next slide. Dr. Walks?
Future of care. AI-driven early detection, genomic risk stratification, personalized treatment pathways, goal of functional cure.
Next slide. Dr. Lawson?
Summary. Myeloma is a systemic disease with multiple organ impact. That's true for most systemic diseases. But comorbidities significantly affect outcomes. Also true for everything we've talked about. Early detection is critical. I think that's true for literally everything. Integrated care improves survival. This is an interesting summary that could be used for most of our presentations.
That's true. Very true. I think that's the last slide. Any more slides on that, Simon?
Dr.
So,
Maxey, your
yes,
slides got me really thinking about this. I have thought about this disease a lot because of the death of one of my colleagues years ago. So we'd already said that there was a higher rate in African Americans, which begged the question, what is the rate in sub-Saharan Africa? And it turns out that the pool prevalence is around 7.8%, but maybe as high as 28.6% reported in some studies in Togo. And with all of those statistics, there was the comment about underdiagnosis. The other thing that you had in your slides that had me wondering, I haven't had time to research that one, is what's the mechanism of this disease? Is it something that happens because of an epigenomic impact on a carrier gene, or is it a direct attack to the stem cells by the offending environmental agent, or can it just occur randomly because of an underlying genetic predisposition?
and the answer is all of the above. All of the above. The real answer, they're not sure. But it definitely with pesticides and other toxins like benzenes and Agent Orange, Those people have a higher incidence, but it has to have a genetic basis too. So we have to, there's a lot of research that needs to be done on it. But the main thing is if you're suspected by having any of these symptoms of weakness, shortness of breath, don't rule it out. Go get checked out. And that plasmapheresis is a very important diagnostic tool. Ultimately, the bone marrow needs to be done. So don't be scared of those needles, but you do need some of these tests, and especially if they show up with lesions and other things we need to know about. Are there any
So,
comments or questions in the chat or any other discussion?
so while we're looking in the chat, Dr. Maxey, I'm going to pretend that I'm in the chat because I have a comment. Um, One of the things that I think we could add to this conversation, Dr. Lawson made a comment about our summary slide being applicable to many of the things that we talk about. And I think the comment that I'm going to make is also applicable to many of the things we talk about. I know two people very close to me over the last couple of years that were diagnosed with multiple myeloma. One of them got early treatment, had a bone marrow transplant, was cared for in a high-end medical environment, and did very well, and has recovered and is back playing with her grandkids. Other person I know was diagnosed and was treated over some period of time with some chemotherapy, and then was told that he needed a bone marrow transplant. And he had to. This is the part. In order to get the bone marrow transplant, he had to have care provided by people that he knew that were close to him over the course of a month or more. And this was someone that didn't have people like that, didn't have kids that could take a week off from work and come stay with him, and then other folks that he could stay with or could stay with him. And and then they said, well, you don't really need the bone marrow transplant. We're going to just give you some more chemotherapy. Now, I may not be the world's smartest doctor, but I think if the chemotherapy is where they started and they told you they were moving to the bone marrow transplant, just to go back to the chemotherapy may not be the first option. And I
Mm,
mention this because there are so many of us that feel we have good insurance coverage because healthcare is the only people that can afford to pay for their own healthcare, I think, are Elon Musk and Jeff Bezos. And even them they may not even have enough money. Healthcare is really, really expensive. And just because you have health insurance or you have coverage doesn't mean your insurance company will pay for the care you need. And even if they'll pay for your care, it doesn't mean, and especially with this illness, because of the kind of care that's needed after they do the bone marrow transplant, it may not be available to you, not because they won't give it to you, but because you don't have the additional resources, that holistic approach and all the things we talk about, you just may not have those kinds of resources. So, something to think about.
that's a
Mhm.
lot to think about, but you're so right. And they may not treat you because they don't have enough money to pay for it. They make economic decisions that your life may not be worth that much money. And I'm sure that's made in many cases of Black people. Dr. Neighbor Stevens, you about to say something?
No, I was checking the chat. We don't have any other comments relevant to this.
Well, good. We can have a final comments, starting with Dr. Lawson.
I just want to follow through what Dr. Walks was saying, and point that we've noted and also true for a lot of these kinds of issues is that one way that you can get fairly good treatment and care is, of course, participate in a clinical trial, which is often unavailable, not just for African Americans, but for anyone who's not close to an academic medical center. Again, um, we can complain or say that it may be exploitive, that maybe you could end up in the control group. The bottom line is that clinical trials, unfortunately, especially for a severe chronic disease, which we don't have good treatment options, is often many times the best option. Surprisingly, it's too, I live in the DC area. Um, it's interesting that several of the medical centers, John Hopkins, for instance, we also got something called NIH here, and these centers have one heck of a time getting a diverse population in terms of their studies for a whole complexity of reasons we've discussed before. But again, I just want to again work with a number of organizations, including the National Medical Association and others. We need to do more that we can to get folks into these trials, not only because they can lead to some effective treatments in disorders that are ravaging our community, but also a very practical factor that this is one option where you can get treatment where treatment may be inexpensive or pretty much non-existent in terms of your community setting.
Hey, thank you. That's awesome. Dr. Walks.
Yeah, thank you, Dr. Maxey. I want to just mention how challenging these kinds of chronic, long-term, if you don't fix it, it'll kind of kill you in many different ways over time kinds of illnesses. From a mental health perspective, it's hard to go from someone who is because something like multiple myeloma, it'll just come by itself. It's not like you got sick from something else. You didn't your body didn't start breaking down and you noticed that you were getting it can happen. And so accepting that you have a chronic disease, potentially fatal disease if you don't take care of it, and being an advocate for the kind of Dr. Maxey, in these slides, you mentioned a lot of different workups that need to be done to be clear about this illness being something that you now are going to be treated for. And so there is a lot of acceptance of, yes, there's something going on. There's a lot of advocacy. I need all these tests done that needs to happen. There's a lot of sometimes insisting and demanding from your insurance company that I do need to get this next test. I do need to have this next thing done. And so I just think it's important for us to understand that all of that can be hard. All of that can cause significant amounts of stress. People can get depressed. People can get hopeless. Somebody can say to you, well, you're already in your 70s and you're going through all of this. And so there are so many psychological aspects of chronic illness as you become less and less young and people begin to, if I fall over, Dr. Maxey, nobody's going to write, oh, he was so young. They're going to write, oh, that man fell over. And
Mhm.
so as we get out of the young person category, we have to advocate that we still have some things left to do. We are still vibrant. We still have things to contribute. And as the pastor said in church today, Dr. Maxey, he said, we are supposed to be people of consequence. And I know that you and Dr. Neighbor Stevens and Dr. Lawson are already people of consequence, and you have more consequential things to do. So nobody gets to tell us that our time is up and the time that we have left is not important time. So we have to advocate for ourselves.
Our pastors coordinated with each other on that same message, Dr. Walks. Same message. Dr. Barbara Davis Stevens.
So I want to use the discussion about this very difficult disease and the problems that you all were just outlining in terms of access to care to jump to a broader advocacy point that I would like to make. In each of us in our own communities and in our own way need to be, first of all, aware that the Medicaid cuts that were
Mm.
passed will start hitting and taking effect this fall. And I heard out of the mouth of our president, nobody this was not a social media thing. I heard it out of his mouth that we can't afford Medicaid, we can't afford daycare or any of the social service programs that we most certainly can afford and should provide. So I am urging everyone to be an advocate in your own communities. Stay stay on. I was going to say something else that you all would have slapped my hand for. Stay on the case of your local, your
Yeah.
state, and your national congressional politicians to hold them accountable and make them do what needs to be done. They don't want to do it. At least some of them don't. I shouldn't say none of them. A large number of them don't, though. And we need to do everything we can to push them in the right direction.
Thank you, Dr. Neighbor Stevens. And I'm reminded of a situation of vulnerability.
Mm.
Who has to fight these wars? Who's at the pointy end of the spear? It's usually people who are black and brown, not the people in the White House. They don't care. And
For their children.
we get exposed to these toxicities. We get exposed to the rivers in Detroit and Michigan that are polluted. We get the pesticide that make us more vulnerable to this. So we're very concerned. The point that Dr. Neighbor Stevens makes is very good. We're at the
Yeah.
pointy end of the spear, and it may be genetic or it may be genetic vulnerability, but we get it more than others because we're the ones at the pointy end of the spear. The other thing that I want to compliment Dr. Walks and Dr. Lawson on is that it's very important the psychiatric, psychological issues of stress and going through this. That I don't want to say that holistic medicine and things aren't good, but you have to be careful. I think the main thing I would warn to people of color is don't buy into these vitamins that are just going to help you. Make sure you coordinate with your cancer specialist, your endocrinologist, your cardiologist, because everything can work together. You need to take the right doses and not do things that are going to blow your kidneys or your heart out. Be careful. Follow recommended medical, historical, journal peer-reviewed advice, and don't just start taking a bunch of vitamins saying you're going to be natural. This is very serious. And one slide said that all of this holistic stuff does not cure the cancer. It may help another part of you, but the cancer needs to be seen and taken care of directly while you have the other parts to support your human element, your brain and your other parts of your personality. Thank you very much, everybody. Enjoy Easter Resurrection Day. Thank you, Dr. Lawson, Dr. Walks, Dr. Neighbor Stevens, and Simon. Thank you for today. Have a great day.
Bye.
Bye bye, everyone.